All right, so we appreciate everyone's support in joining us in today's Future Pediatrics session. We know we have a lot of folks who are virtual. As part of the adventures in meeting management, our next speaker, Dr. Plessis, had a minor traffic event and is fine, but is going to be doing his presentation virtually and joining our virtual audience. So bear with us for 1 second while we get all this sort of teed up. And thanks so much for your patience and understanding as we work this through.
Hi, everyone. I'm really sorry I can't be there with you in person, but I'll do the best I can from where I am. I am Audrey du Plessis. I'm director of the Prenatal Pediatrics Institute at Children's National. I am a child neurologist by training, and so although today's talk will be general and at a pretty high level about pediatrics in general, there will be a neurologic slant to it. Next slide. I don't have any disclosures to make. Next slide. For those of you that have heard me speak before, you will know that I'm pretty passionate, and some would say messianic, about what I'm going to talk about today. And it relates to what I consider to be one of the major next frontiers in pediatrics. And that is the involvement of pediatricians within the intrauterine period, and how we get information from one phase of life to the next, both from intrauterine to postnatal and also from neonatal high-risk babies to the postnatal care that pediatricians deliver. So the topics are going to broadly focus on continuity of care and what gets lost in transition. And here we have a slide of an obstetrician handing off what looks like a pretty robust youngster to the pediatrician. Often the amount of information that accompanies this transition is limited, and that's what I'll be speaking about today. Next slide. So this is the conventional model of the roles of obstetricians and pediatricians, where the obstetricians and MFMs will take care of babies, will take care of babies and mothers between conception and delivery, and then there's this handoff to pediatrics. Next slide. I'll try and convince you that pediatricians should be involved from a much earlier stage in high-risk pregnancies. And there's, of course, a precedent for this because we take care of extrauterine fetuses that are born very prematurely and have a lot of experience with the maturational challenges that they face. Next slide. So a lot of what I'm going to say originated or found its foundation in the work that David Barker did in the 90s and even before that, in which he examined the relationship between birth weight and a number of later life diseases. His most prominent work was in studies regarding the Dutch famine of 1944. So the basic story was the Germans invaded Holland from the east, and when they did so, the Dutch farmers were cut off from the more urban areas in the west of Holland. The Dutch then went on a rail strike and to limit the mobility of the invading German army. And along with that came famine, essentially. So between the fall of 1944 and the spring of 1945, when liberation occurred, there was a period of intense malnutrition. And the Dutch, being like most West European countries, they documented everything, including the number of potatoes that came to each household. So they were able to get a semi-quantitative measure of the nutritional state of these households. What David Barker and his team did is they evaluated survivors from this period and examined the relationship between whether they were in utero at that time and when they were conceived. So what part of the intrauterine period they as fetuses were malnourished. And the long-term outcome of that was really an eye-opener on a number of fronts. And I'll get back to that in a minute. But this is where the story originated. Next slide. So I'm going to start off today just with a theoretical baby boy X and sort of build it up from here. Our baby boy X is born at 37 weeks, so he's not quite premature. He doesn't hit any alarms on the prematurity scale, with a birth weight of 2.5 kilograms, which puts him on about the 15th percentile. So he doesn't hit any alarms on the SGA scales. His delivery was via normal vaginal delivery, and he had, after spontaneous onset of labor and no intrapartum concerns, good APGARs, was admitted to the nursery, initially had some minor feeding issues, but these resolved, and he rapidly gained weight after discharge and in follow-up at his regular pediatrician visits. He was also making good progress neurodevelopmentally on the Denver developmental scales. Next slide. Back one slide, thanks. At around 2 years of age, there were some concerns that emerged about his language and social development being delayed, and close follow-up was recommended. By 3 years. There was further fall-off of his language milestone acquisition, and speech therapy was started. And then at 4 years, his social withdrawal and repetitive behavioral stereotypies had emerged, and he was diagnosed by a developmental psychologist as having an autism spectrum disorder, and ABA therapy was started. On other fronts, by the age of 2 years, he was well above the 97th percentile, and recall that he was in the 15th percentile at birth. And at 3 years, he was diagnosed with obesity. At 12 years, he was both obese, even more so, and he was diagnosed with diabetes. And so we'll return to this youngster a little later on in the talk. Next slide. So I will try to convince you that baby boy X's problems were initiated, or their origins were in the fetal period and due to an adverse intrauterine environment. Next slide. And as there are many different forms of an adverse intrauterine environment, I'm going to use placental failure and fetal growth restriction as the theme of the next couple of slides, because number one, it is very prevalent, much more prevalent than I think most of us recognize, affecting almost 500,000 pregnancies in the US each year. Next slide. So fetal growth restriction, I mean, the problem starts off with a definition, which is failure of a fetus to achieve its genetic growth potential due to restrictive environmental influences. And of course, how does one define, other than measuring the parent's height and weight, how does one define genetic growth potential, and how do you measure it? The diagnosis, as you know, is made on the basis of population, fetal and neonatal growth charts, and these are usually not adapted geographically, by ethnic background or race, and it's sort of becomes a one size does not fit all situation. Next slide. The consequences of fetal growth restriction are many, starting off with the most severe consequences, that those would be fetal demise and overt fetal brain injury. Prematurity is a common complication, and the combination of prematurity and growth restriction is particularly worrisome, and they're more prone to perinatal asphyxia. But if they can run the gauntlet of those hazards successfully, they often appear in pretty good shape initially and over the first year or two, much like our baby X. And thereafter, there are a number of neurologic, psychiatric, and metabolic cardiovascular complications that you can see listed on the right side of the screen. Next slide. Suzanne Miller wrote a very good review a couple of years ago highlighting the neurodevelopmental consequences that included motor consequences, both gross and fine, cognitive and learning consequences, behavioral difficulties, and these ranged from attentional issues to psychiatric, mood and affective disorders, and also autism spectrum disorders. Next slide. In fact, fetal growth restriction has been associated, especially, as I said, when it occurs in premature infants, which it often does, is associated with, or has been ascribed 25% of the special education costs in the United States each year. So it's an astronomical amount of money. Next slide. So I'm going to move on now to developmental plasticity and show you that this is indeed a two-edged sword that exposes the developing fetus to long-term adverse consequences, but is also a potential window for intervention that is currently missed. Next slide. So many of you are probably familiar with this type of diagram, which shows the critical periods, and I'm focusing now on the brain, critical periods of development across gestation, starting off with the neural tube formation, proliferation, migration of neurons, and then the critical parts of brain development, those that really separate us from, and our abilities from those of primates and other animals, is this period of organization. And this is a critical period. And by critical period, I mean, this is a period in time when the tissue, the brain tissue, both globally and regionally, becomes more sensitive to stimulation. And if the stimulation is normal, that results in normal organization of the brain. If there's adverse stimulation, the brain development is particularly sensitive to becoming derailed by the environment. And this critical period for language, cognitive development, and a host of other developmental issues actually extends from this third trimester until about 3 years of age, and then begins to wane. Next slide. So at birth, after a normal gestation, the brain is hopelessly overendowed, and there is a massive pruning of elements. So there are way too many cells, there are way too many axons, dendrites, there are way too many synapses. But these are then trimmed down and pruned in such a way that the brain is sculpted according to the underlying blueprint. So it is this this foundation upon which subsequent rehabilitation can be built if the need is recognized. Next slide. So, as many of you know, the notion that a single genome resulted in a single phenotype has long since been debunked. And it's now known that you can get a range of different phenotypes from the same genome. And these are environmentally influenced through epigenetic mechanisms. The environment triggers act during these critical developmental periods when there's heightened sensitivity stimuli. These critical periods, as I said earlier, are time limited, so they wax and wane. So in the third trimester, there is a blooming of sensitivity to the environment, which then over the subsequent 3 years wanes. Once a critical period is over, sensitivity to environmental influences both, can we go back? Back one. To environmental influences, both positive and negative, decreases, and the system and the nervous system becomes programmed and entrenched in the hardwiring that it has at that stage. Next slide. So let's get back to baby boy X. What was lost in transition? One of my biggest issues with the way we practice medicine these days is this notion that health and disease is a binary phenomenon, that you're either normal or abnormal. And so this youngster, as I mentioned, was not premature within the category that most of us are alerted to following them in a more focused manner. And the baby was also not SGA, i.e. not less than the 10th percentile at birth. But what we didn't know was that the obstetricians had been following this baby over the last 6 weeks of gestation, and the baby's expected fetal weight dropped from the 80th percentile to the 50th percentile. So there was a period there, although the baby did not drop out of the normal range, where the baby's weight gain was a concern. That because the baby was had good APGARs, was AGA, all of that sort of got lost in the mist. Also, the antenatal Doppler studies had shown that the placental function, as assessed by the uterine artery Dopplers, was normal. What was not mentioned was the fact that there was cerebral vasodilation and decreased resistance of the cerebral vasculature as a compensatory response to fetal hypoxemia. So that's sometimes called brain sparing, and it doesn't really spare the brain. It's more an indicator that this baby is at risk for cerebral hypoxia. Next slide. So what opportunities, what windows of opportunity were missed here? I mentioned the UA Dopplers, and because they didn't show altered placental resistance, it wasn't considered a case of placental failure. I mentioned the brain sparing story, the SGA and prematurity, so the baby slipped between the criteria. And the baby's perinatal course was reassuring. In fact, when it comes to weight gain, it was probably excessive for this particular baby. Next slide. So the current situation and the critical steps going forward are that I believe that my bias is that there needs to be greater involvement of pediatric specialties when it comes to the development of management and diagnostic protocols for their future patients, for higher risk fetuses. There's clearly a breakdown in optimal communication from the prenatal period to the neonatal period, but I would go so far as to say there's also suboptimal communication between neonatal care in a neonatal intensive care unit and how that gets transferred over to the caring pediatrician after discharge. What we need is a targeted monitoring and individualized care plans for children delivered from an adverse fetal environment, even if there were no neonatal complications. In fact, especially if there were no neonatal complications, because these are the kids that drift off into the community and remained under the radar. And and so I should have focused on this more. They remain under the radar until that window of opportunity has closed, until the plasticity period, which lasts until about 3 years for most of these functions, has passed. And by that stage, the child is hardwired. It has been shown, by the way, that early life interventions for infants born from a growth-restricted intrauterine environment have a definite positive influence on outcome. Next slide. I think this slide basically summarizes again what I've just said. Many of the chronic childhood neurodevelopmental and other health conditions, such as this child's obesity and subsequent diabetes, can be traced back into the fetal period in many cases. There is this prolonged latency period from the time of birth when everyone's feeling good about a baby and it's a good save, or various other terms that are used. But then the baby drifts off into the community and is no longer tagged as a high-risk baby that might benefit from early interventions, focused interventions. And then finally, the issue that I spoke about, i.e. that the clock is running down during those first few years. Next slide. And I think I'll stop there. I had a couple of other slides, but I think we're running out of time. I'm happy to answer any questions.
Yes, one question on the Q&A online. This question is, why is the infant having brain hypoxemia? I'm not going to say that correctly. Hypoxemia, if the placental is fine. Please explain the possible mechanism.
Yeah, so that's a good question. So placental failure, most placental failure with fetal growth restriction occurs after about 32 weeks of gestation. And although it's not fully understood, it is not necessarily on a vascular basis that late fetal growth restriction develops. And it's thought to be more at the level of between the fetal circulation itself and the maternal circulation. There is a barrier, a selective barrier. And if that's not functioning, even though the vasculature in the placenta may be at the right resistance level, maybe perfusion is okay, but it's more a matter of diffusion of or transfer of oxygen and other substances across that membrane. Many people out there that take care of kids during this period, and I'm not talking about MFMs because they know this stuff, but it's often assumed in the community obstetric world that if the Dopplers, the UA Dopplers, are not showing signs of increased resistance, that it's not placental failure, and that's not the case.
We have a couple more questions. First is with COVID, either illness or the vaccine, are we seeing any more placental impact or malfunction?
The short answer is yes. A lot of the reports are anecdotal still at this stage, but there appears to be an inflammatory response at the level of the placenta, as well as potentially in the vasculature of the fetus, where inflammatory changes have been invoked as a cause for strokes in some cases, other forms of destructive brain injury. But at the moment, these are largely anecdotal, but they are increasing in number. So I suspect there is a connection.
Thanks, Audrey. There are three questions here that sort of overlap. I'm going to read each of the three, and then you can give one general response, and then we'll be ready to move on. So for high-risk deliveries, babies should be referred or who during the first 3 years of life. Second question is, so should we as pediatricians be asking for this information from the OB? And if we identify such an infant, where do we refer the child? And what should a pediatrician do if a family shares information about fetal growth concerns?
So
They all are sort of,
yeah.
The ball's in your court. We'll wind up with this question.
Yeah, so obviously that is the elephant in the room. How do we go about, and that's a subject that will require hours of discussion, but it is the next challenge, i.e. getting obstetricians and MFMs aware of the fact that it's not only about survival and good APGAR scores, that there are other events happening within the fetal intrauterine period that are important to convey to pediatricians. Equally, as I said earlier, there are those patients that spend time after birth in a neonatal intensive care unit, and oftentimes the fetal information gets to those caretakers, those neonatologists, but once the neonatologists have done what they need to do, that information again evaporates and does not carry through. Ideally, one would have, and this is one of the goals of my group, is to have a campaign where we develop protocols both for diagnosis and for focused intervention, and that those protocols get disseminated out to the pediatricians in the community. And it says, so if an OBS has a small for gestational age baby or a baby that had intrauterine complications, depending on what those complications are, that there's a list of recommendations for dietary control, glycemic control, and of course, that there's closer and focused attention to issues such as language development, fine motor development, and so forth. So that is where the work needs to go. We were on the verge of starting this work, and we're actually working with Ellie Hamburger at one point, and then COVID came. So, like most things, we can blame it on COVID, but we are energized to restart this campaign, and there's going to be a lot of work needed. Thank you.